So it's my pleasure to welcome our last speaker, Dr. Fernandez Perez, who is coming from National Jewish. He has added quite a bit to our understanding of chronic hypersensitivity pneumonitis, which is his topic today. Thank you.
Thank you for a very nice introduction, and I want to thank the Foundation for the invitation. So, oops. There we go. All right, I think we're back. So I think in order to, these are my disclosures, to try to appreciate how much progress we have made in hypersensitivity pneumonitis, we have to review where we have been, where we are, and where we're going. And so I'm going to touch on the frequency of the disease, how bad is hypersensitivity pneumonitis. I'm going to go over the evolution of the diagnosis. We're going to talk about prognosis and treatment. And I'm going to share with you some of the work I have been involved for the last couple of years. So hypersensitivity pneumonitis is one of the most common non-idiopathic ILDs around the globe. And depending where you practice or where you are, it's probably the most common interstitial lung disease. And I'm showing you here the age-adjusted mortality per 1 million per year. And as you can see, look at the trend. It is increasing exponentially over the years and is not slowing down, an average of about 4 to 7% per year. And to put this into perspective, if you use the same analysis, using the same source, which is from the National Center of Health Statistics, you will see that the mortality rate of pulmonary fibrosis, including IPF, excluding other causes, is in fact slowing down by 0.6% per year. The other issue is, like other interstitial lung diseases, CHP is not just only a contributor, but it's a common cause of underlying cause of death. When you look at the incidence and prevalence of the disease, a striking finding when you look at a national database is that might not be surprising for many of you who work in an ILD clinic, is that patients are arriving late to clinic. And a significant proportion of patients are presenting with evidence of lung fibrosis on imaging. And think about this for a second. Hypersensitivity pneumonitis is a preventable disease, which speaks volumes about the importance of trying to increase awareness through venues like this to try to identify that exposure, identify the disease, remove the patient from that exposure, and refer that patient early on to try to see if we can prevent disease progression. Farmer's lung is probably the earliest prototype of hypersensitivity pneumonitis, and many cases were described back in the mid-18th century during the agricultural revolution, and it took 300 years to get basically to the late 1980s when we start to see the first few early reports of a diagnostic criteria, which were quite limited because they used to lump multiple variables poorly defined to try to capture the early form of the disease. And then a few years forward, around 1992, we come across the first published randomized study looking at the effect of pirfenidone, again, prednisone, in patients with acute hypersensitivity pneumonitis. And this is the time when probably the questionable value of the inhaled and serologic antigen-specific testing start to gain some traction. Not surprisingly, at that time, the disease was mostly dominated by allergists and immunologists. What I'm showing you here is the earliest attempt to try to characterize the disease, is the most quoted, and conceptualize hypersensitivity pneumonitis based on a time-based classification as acute, subacute, and chronic. And then we arrived 10 years later to the probably most modern non-systematic review of the disease by the NHLBI, which emphasized the importance of not disregarding or ruling out the disease if the patient did not have a compelling exposure history, or if the patient had a negative specific antigen specific test. And I think that we have partially at least answered, fortunately, some of the many questions they proposed at the time, including the frequency of the disease, the stratification, the natural history, the diagnostic testing, and specifically the value of the CT test in the diagnostic algorithm of hypersensitivity pneumonitis, and the prognostic value of the interaction of the exposure and host risk factors in informing risk and outcome in hypersensitivity pneumonitis. Then by the year 2000, thanks to many studies and the observation by Dr. Keene, Pardo, and Talmadge Keene, it had already become evident that fibrosis and also the relative contribution of inflammation really was an important predictor of prognosis, and also was quite valuable when we had to make treatment decisions. And at that time, also it became evident that fibroinflammatory ILDs like HP really had a very heterogeneous course. And all this was eventually highlighted by a multi-center study, a cluster analysis that prospectively looked at patients with hypersensitivity pneumonitis that show that most cases will not in fact fall into this time-based classification, but better fit a two-cluster model conceptualized as non-fibrotic or inflammatory or fibrotic. And I would add with a known or indeterminate or yet to identify anti-antigen exposure. We also have learned over the years that there are several non-fibrotic CT features that can help predict the post-test likelihood of hypersensitivity pneumonitis, and when combined with a very compelling exposure history, can help establish the disease in many cases. On the other hand, if you look at the histopathology, there are several diagnostic features that have been evolving in this disease. And just to give you an example, if your patient with fibrosis or fibrotic HP has a biopsy, you may see evidence of bronchial eccentricity as shown here. And this may be a clue in the appropriate clinical context that the patient may have hypersensitivity pneumonitis. Interestingly, however, a very recent study looking at the histopathology of UIP by the UCSF team just recently showed that you can have evidence of bronchial-centric fibrosis in the setting of any type of UIP, especially IPF. Therefore, this feature is not necessarily an actual positive, pertinent finding that will always rule in the diagnosis of hypersensitivity pneumonitis. And so the other issue that we have observed over the years is that there is a group of patients where the clinician might not be able to precisely identify that exposure, and those patients appear to be at higher risk for worse prognosis. And there are several reasons why the clinician might not be able to identify the exposure, including but not limited to the issue that many idiopathic ILDs are misdiagnosed as hypersensitivity pneumonitis. And it is this disease at this stage in this group of patients who have a progressive course of the disease that we have not yet identified exposure history that I fear the most. It's actually one of the many monsters we face. It's our nemesis. Because it is here when the clinician realizes that given the limitations of the available traditional testing and the lack of diagnostic precision tools, that diagnostic uncertainty in hypersensitivity pneumonitis, in fact, is common. Therefore, there is a significant unmet need to try to refine that working diagnosis of hypersensitivity pneumonitis. The image on the right, you have seen this before. This is a heat map looking at the different transcripts between IPF and hypersensitivity pneumonitis. This was a semi-diagnostic study done a few years ago looking at microarray analysis of lung tissue to help distinguish IPF from hypersensitivity pneumonitis. Very encouraging, very nice study. However, only looking at patients with a typical presentation and not those patients with a working diagnosis. And although we're not there yet, I think the horizon looks somewhat bright. And just to give you an example, you might be aware of the diagnostic predictor of UIP using transbronchial lung tissue biopsy samples, looking at gene expression by RNA sequencing, which is already available. And in this study, patients, among the patients who have a non-classifiable fibrotic pattern on histopathology, a confident diagnosis of UIP was significantly made more frequently when a gene expression classifier was used as opposed to just histopathology alone. And so in the absence of diagnostic precision tools, the way we make the diagnosis of hypersensitivity pneumonitis, like any other complex disease out there, is by probabilistic reasoning. And so the fundamentals of making the diagnosis basically relies on three major domains. You take the history, the imaging, and the bronchoscopic results. And if the patient meets criteria with typical findings on these three domains, then you can establish a diagnosis. On the other hand, if the patient only meets one domain, then and only then you have to move forward to try to get more testing to try to decrease diagnostic uncertainty. Now, antigen-specific testing also, we have learned over the years that it appears that possibly may have a role as exposure assessment tool, but not just yet as a routine diagnostic test for patients who have a working diagnosis. And the history, which of course refers to the frequency of the disease, where you practice the epidemiology, the clinical context of the disease, and that environmental and occupational history that you have to take is the most important domain because it will always determine the predictive value of any diagnostic test that you will take afterwards, such as the CT test or the BAL. And indeed, this was shown by the recent International Modified Delphi survey that enlisted pulmonologists all around the world, and of 18 diagnostic criteria that made it by consensus, the history of environmental exposure known to cause HP was found to be the most valuable. And then we arrived to this important study by Dr. Walsh, which showed that there is significant poor inter-observer agreement between clinicians and between multidisciplinary teams when it comes to the diagnosis of hypersensitivity pneumonitis, highlighting the importance of trying to standardize the diagnostic criteria. And in response to this, as you all may know, we hope that the incoming diagnostic guidelines from ACCP and ATS next year hopefully will increase disease awareness, will help enhance diagnostic certainty, and help the clinician out there and provide them with decisions to help maximize the clinical decision making, and hopefully that will maximize patient outcome. Moving on into prognosis, this is an area where we have seen a lot of growth in hypersensitivity pneumonitis. If you take, for example, clinical variables, in addition of the frequency of exposure to the antigen, being a man, having more than 20-pack year history of smoking, or having an acute exacerbation of the disease. Age is an important prognostic indicator because it's associated with disease prevalence, the presence of lung fibrosis, and mortality as time moves forward, independent of underlying disease severity. In physiology and imaging factors, probably over the last 50 years, evidence have consistently shown that the most reliable biomarker of early morbidity and mortality is probably the extent and the presence of lung fibrosis more than any specific feature or the pattern of fibrosis on imaging. And in addition of the identification of genes found to lead to disease susceptibility, investigators have also looked at predisposing genomic factors and biomarkers that have been associated with idiopathic pulmonary fibrosis to help stratify and understand patients with chronic hypersensitivity pneumonitis. And specifically, the one that probably deserves mention are the telomerase abnormalities that are associated with short telomere length, which appear to predict an increased risk for the development of lung fibrosis, and is also associated with shortened survival. And last but not least, the presence of fibrotic factors on histopathology and outcome and metrics of outcome also have been shown to have some value in prognosticating the disease. Now, I think an important area is also trying to reliably and timely identify patients who are going to progress. Who are those patients? And then trying to understand the molecular attributes of those patients for multiple reasons that were explained and were shown by prior speakers today in this podium. And so over the last couple of years, we have been trying to characterize the gene expression in a group of patients from peripheral blood with well-phenotyped chronic hypersensitivity pneumonitis. And according to the presence and absence of disease progression characterized by imaging factors, by clinical characteristics, and functional change over time within 24 months. And we nicely identify 74 genes that can help identify these two groups of patients. Then we ask the question, what are the gene expression similarities between patients among these two groups that can help us give a much better idea who are those patients. And then we apply a unsupervised cluster analysis to this set of 74 genes, and we identify 4 3-patient clusters based on disease severity and progression according to those gene groups that remarkably characterize the prediction of progression above and beyond just the clinical assessment alone by decreasing that prediction error and enhancing the accuracy of that prediction only by clinical assessment when we added the genes. And this is a signature that we're in the process of validating across a broad population. Moving on into therapy, very briefly, it's important to remember that hypersensitivity pneumonitis is an antigen-specific disease that occurs in patients who are genetically susceptible. And when they are re-exposed to that antigen, that type of exposure, the lung microenvironment, as well as host predisposing factors will determine that initial fate of the adaptive immune response, leading either to an HP immune reaction or a protective one. And so, therefore, it's extremely important that elimination of the inciting antigen happens early on because it may have a significant impact in preventing disease from developing and progressing. In terms of management, I will not be able to touch on every permutation of therapy, but suffice to say that anti-inflammatory agents still are the mainstay of therapy for patients who have active disease, and corticosteroids remain the first-line agent for some patients for remission induction. Now, there is a group of patients that appears to have an autoimmune flavor or autoimmune features, and we have been interested in looking at a type of dysfunctional immune cell that was first described in our institution and is commonly found in elderly mice and humans with autoimmune disorders and infectious diseases, H-associated B cells. And they produce autoantibodies, they activate autoreactive T cells, but they are excellent antigen-presenting cells, at least in mice. And we have observed that compared to controls, they are a very high elevated number in the peripheral blood and BAL of patients with different granulomatous lung disorders, including hypersensitivity pneumonitis. Therefore, we think that based on observational data, B-cell depleting therapy may possibly be a target and have a role in the near future. And this is currently under prospective evaluation in a French multi-center study. And right now, we're in a crossroads, as likely we're going to be moving away from just immunosuppressive therapy as the only option to treat patients with a fibrotic progressive phenotype, and we're going to move toward more a targeted anti-fibrotic approach to treat these type of patients. And this is good news, especially for those who have hypersensitivity pneumonitis, which was the most prevalent progressive ILD other than the IPF in the recently published INVIL study looking at the effectiveness of nintedanib on the rate of decline in FVC over 52 weeks. There is also a phase 2 trial, which is about to close, looking at the impact and effect of pirfenidone, either alone or as a add-on therapy. And likely the study hopefully will shed some light on the effect of this medication and the importance of combination regimens in patients with a progressive fibrotic phenotype. So in summary, what I've been trying to tell you today is that hypersensitivity pneumonitis is a frequent cause of pulmonary fibrosis, and many patients with this disease may present to you with a progressive fibrotic phenotype. I think we're moving away from a time-based classification, and we should be embracing more a prognostic type approach to characterize these patients. Pending clinical practice guidelines hopefully may help improve diagnostic refinement by decreasing practice variability. In the meantime, like any other ILD, we use probabilistic reasoning and collective intelligence, or MDD, to try to characterize and diagnose these patients. And I think in the future, combining these clinical phenotypes with molecular biomarkers of omics, if they are able to be implemented in clinic, will certainly help provide more precise diagnostic, prognostic, and therapeutic information. And therapeutically, I think that beyond antigen removal, yet still the timing, the role, and how the patients respond to anti-inflammatory, anti-fibrotic therapy is yet a question that needs to be properly answered. And in regard to the answer to the question of the title of this presentation, have we made progress in addressing the knowledge gaps in the diagnosis and treatment? The answer is yes, but it is much more to be done. Thank you.